Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator.
Okay, so what we're going to talk about is overdentures, and this is a topic that I'm very passionate about. It's a prosthesis that I've seen help a lot of people improve their quality of life without breaking the bank. And I think nowadays, with the rapid and abrupt changes that we had the last few months, this treatment option might become even more pertinent in our tool of options that we can offer our patients. I am at the University of Pennsylvania currently. I've been here for 5 years. I developed and direct the graduate prosthodontic program, and actually tonight we have our first graduation of the first class of prosthodontists from Penn Dental Medicine. So it's a really big day for us, and we're very happy. It was a lot of work, and those residents are really making history in our school. So without any further ado, let's get started. So I want to introduce you to our first patients. The first two patients that we have is Jennifer and George, and you've probably seen them before looking a little bit different in the past, but you can imagine how devastating it would be if they were suffering from complete edentalism in their pursuit of job interviews or a social life or parties or simple dinners. Maybe those two patients are not exactly looking like that, but so many other of our patients do look like that. And you can imagine how devastating it would be for them to find a job or to socialize, make friends, go on a date, or so many other problems. How many would you say that we have, at least in the United States, we have 35 million people that are completely edentulous, and I'm sure those numbers might be similar in many other countries in the world. And despite the overall quality of life that is increasing generally in our times, still edentalism is going to remain stable, if not expanded in the future, because although quality of life and dentistry and prevention are improving, the absolute number of people that are going at elderly ages is increasing. So mathematically, the number of completely edentulous patients will potentially increase. And we have to be ready to treat them all. You can imagine now, if you have a high-profile job like this politician and you're trying to convey a message, if you have a removable prosthesis that it's unstable and something like that happen, how effective would your speech be? People would not pay so much attention to what your message is, but they pay attention to this mishap. And it is really unfortunate to live in this time and not being able to provide our patients with something that is more reliable and something that would allow them to focus to the real life and forget a little bit about their dental issues. So traditionally, when we want to treat complete edentalism, we would turn into a complete removable prosthesis such as this one. And we all know the limitations, not only when it comes to speech and social life, but when it comes to simply eating. Every time we deliver dentures, we teach our students, residents, and patients that the chewing ability is only 1/6 of what it was when they had their teeth. So they have to eat different foods, softer foods. They have to eat in a different way, only with the posterior teeth, try both sides evenly. We have to explain to them that they have to remove those at night. So it's changing their everyday habits, it's changing what they can eat, it's changing which restaurants they can go to. It's a real learning curve. Of course, there is still room and there is still patients that can benefit from that. But as we say, dentures are a replacement for people that don't have teeth. People that may have teeth now and they're not restorable, there might be better solutions than dentures. Of course, nowadays we have reached a point where osseointegration with dental implants as well as biomaterials is at such high levels. So much improvement has been done that we're able to provide our patients with highly sophisticated prostheses on several implants with very reliable and predictable results. Several implants, maxilla, mandible prostheses with very strong materials, long-term success rates. Literature keeps coming up showing that this treatment is something that we should be considering. So those are hybrid prostheses or implant-supported fixed dental prostheses or implant-supported fixed complete dentures. All of those are different terminologies used to describe the exact same prostheses here. So obviously for patients that might have some teeth that they are not restorable, we're looking at providing something like that is going to give them the best quality of life, the most chewing ability, the most mastication capacity, and really maintain their quality of life to fully dentate people like us. However, is this realistic and possible for all of our complete edentulous patients? Probably not. And there was actually a survey that was done, and there were hundreds of prosthodontists that received worldwide this survey to answer what would be the reason for not choosing a hybrid prosthesis for the patients and going for an implant overdenture or other treatments. And obviously, you can see that the number one reason, the vast majority of the prosthodontists replied that it's the cost. Other reasons were the available bone. Obviously, when we're doing a removable prosthesis, we don't need the number of implants that we need for fixed prosthesis because it's tissue retained as well as implant retained. And another reason is the patient preference. Some of the patients are not looking at having a complete replacement of all of their teeth. Their lifestyle might be different. All they want is that denture that they already have to be a little bit more stable. And we cannot make it more stable just by relining it because unfortunately the supporting tissue is inadequate to provide that retention and stability. So we're looking at implants to provide that retention for them. So this survey was done only 3 years ago, but I was thinking, imagine what the numbers would be now. Now, the last few months, we have had such huge changes in every aspect of our personal life, our professional life, and we can only imagine the impact that this situation with the pandemic has caused to our patients, not only from a health safety issue, but also from an economic standpoint. The fact that we are hit by a pandemic doesn't mean that all of the other problems were solved and now we can focus on one. This is in addition to pre-existing problems. So patients that have dental problems and they were potentially thinking about replacing them with something more sophisticated that we're able to provide may no longer be able to. So we need to be prepared to give them alternatives. And those alternatives, what I think I can help with understand is the implant retained overdenture. And this would be an example of it. Similarly to a hybrid, we can place implants on the maxilla and on the mandible, different distribution, less number of implants, and then the prosthesis is smaller than what the removable prosthesis is, especially when it comes to maxilla, and we're going to talk about it. And it's implant retained and tissue retained. So it really gives the chance to our patient to improve their everyday quality of life without having to go to extreme surgical procedures, bone grafts, and also additional costs that this might have. So let's go through, first of all, the definition of overdenture so that we make sure that we're all on the same page. So based on the glossary of prosthodontic terms, it's any removable dental prosthesis that covers or rests on one or more remaining teeth, roots of teeth, or dental implants. And it's partially supported by natural teeth, roots or dental implants, and as I said, partially retained by soft tissue. So let's look at the types now that we're all aware of. And we'll start from tooth retained overdentures. This is by no means a new treatment. You can see that it was first mentioned in literature in 1958 by Miller. This was again at an effort that dentists were trying to put into giving their patients something more stable, something more reliable than a complete denture. And they were trying to maintain roots of teeth or teeth in an effort to delay the bone resorption that would in return provide better support for the removable prosthesis. So what are the indications to do a tooth retain overdenture? Definitely younger patients. Younger patients, because they would have much longer life expectancy, and we know that bone resorbs over time. So the younger someone is, the more chances that the bone will resorb by a later time, at which point their denture will not be having any support. Low caries risk is very important because the number one disease of teeth is caries. Number two is periodontal disease. So if we already have high caries risk, those teeth that we're trying to maintain would potentially be affected by caries very soon, and then we would have to modify and reline the denture and make several changes. So what would be the advantages then of maintaining some of the teeth in order to create an overdenture? Would basically reduce the progressive residual ridge reduction. As we said, we know that the ridge is going to resorb. We know the mandible is going to resorb much faster than the maxilla. So it is important, just by saving the roots or the teeth, that this bone was not going to resorb, and it's going to give us a better supporting area for our dentures. By saving the teeth, you might increase denture stability and retention, and I say might because it depends on how you're going to use them. Sometimes we use those roots just as a stop, as a vertical stop of the denture, so that it doesn't compress into the tissue without putting any retentive elements. And you can see the first photo right here, just the roots are there. There is nothing retentive about it. So you cannot say that those teeth that you saved there help in the retention, but they help to stop the bone from resorbing. So you have overall better support. This goes back to the basic principles of denture fabrication, our support, retention, and stability. Better load transmission of the prosthesis, improve mastication and ability and efficiency, again, just by increasing the support. Sensory feedback from periodontal receptor, obviously maintaining some of the PDL. There has been some literature, not extensive, that gives the patient the ability to maintain that sensor and have a more close to normal experience by mastication. And the second disease, as we said, when we have periodontal problems, by decapitating, decoronating the teeth and removing the crown portion and maintaining only the root, it will improve the crown to root ratio. It will be easier for the patient to maintain, and potentially you can save and maintain teeth that have even compromised periodontal support. So there are several advantages in doing something like that. Once you consider that this is a patient where I can save some of the teeth because of all of those indications, how do we go about it? How can you start making your overdenture? You have several options, actually. The first option is you maintain those teeth by removing the crown portion of it and leaving about 2 to 3 millimeters above the gingival height on a convex or dome shape design, without any coping, without any attachment. You're just maintaining there. Again, they will provide only support. The second option would be to actually cover those roots or crowns with copings. Traditionally, we used to fabricate copings by cast metal. It would have similar shape, dome shape, to cover the abutments. And depending on whether we need or not need to do root canal, the height of those abutments can be either short, about 2 to 3 millimeters where root canal is necessary, or longer, 5 to 6 millimeters where root canal may not be necessary. It all depends on the exact location of the pulp. If it has receded, sometimes for elderly people, root canal is not necessary, which saves costs, save time, and treatment can move on faster. This could be a good option for patients that might suffer from caries, and by covering the teeth, you expose less to structure, to bacteria, and therefore caries. But you cannot eliminate recurring caries anyways. The third option that you have would be to actually incorporate attachments on those copings. And you can see here in this photo, 2 of the copings don't have an attachment. It's like the second category that we discussed, but 2 of them, they have a cast ball on top of the coping. This ball attachment can be used to retain, to be the retentive element for the overdenture. In this scenario, your overdenture is actually retained. The retention is improved, not only the support of the overdenture. Those attachments can be unsplinted, like in this photo, that are independent abutments, or they can be splinted by a bar. Again, here we have 2 teeth, and they casted a bar. Usually the male is soldered to the coping, and then the female is embedded in the acrylic, and that's how the female would look like inside. So those are the different options when you're thinking about retaining some teeth, on how you can use them. No coping, coping, and then the coping could have an attachment as well. Now, what are the disadvantages? Actually, it's very interesting because for overdentures, tooth retained overdentures, we have a lot of literature to exactly describe what are the complications over time. Actually, one of my faculty members at the University of Iowa, Dr. Ettinger, he has done long-term studies. You can see from 1984 to 2004. We're talking about 20 years long of studies on patients that were treated with overdentures and what were the complications over time. So what he found was that caries is the most common cause of failure. And that's why when we start talking about it, I told you that indication is low caries risk patients. From those patients, he found that 37% of the endodontically treated teeth developed a PA lesion. And caries was more prevalent on the mandible, 14%, versus on the maxilla, 12%. 21 of the abutments that were affected by caries were non-restorable. And then it's an important discussion. If we're not going to use a coping and we have to decoronate the tooth down to 2 to 3 millimeters, which means we have to do a root canal on that tooth, what are we going to cover the access hole with? Options are all of our direct restorative materials, which would be amalgam, resin composite, or glass ionomer. How do we choose? Because number one failure has been found to be caries, then it would be smart to use the fluoride releasing material, and that traditionally is glass ionomer cement. Glass ionomer has the fluoride releasing capability, which means that it has the potential of reducing caries on those particular teeth. On the other hand, it's not a very strong material, and over time it might fail. So you have to think the advantages and disadvantages of those materials to make a choice. Amalgam has very high compressive strength and might last longer, but it provides no protection against caries. So your material might stay there, but you will have recurrent caries. And you see that 21% of the abutments is non-restorable once it gets recurrent caries. From the other hand, if you use glass ionomer, the material might not last for a long time and you need to replace it, but because of the fluoride releasing abilities, the tooth will not have caries. So it will be very simply just replacing the material. And this is what we recommend. Glass ionomer due to the fluoride releasing abilities that it has, and in addition, daily use of fluoride varnish. You prescribe to the patient fluoride varnish, and they know they put it on the abutment teeth morning and night after they have brushed and after they have eaten. And this will reduce the chance of caries. Other complications that they found was that it requires endodontic treatment if you need to decoronate the tooth shorter, which increases time and cost, as we said. Caries susceptibility, which can be controlled with fluoride usage, but at the same time, you need to have a compliant patient that will use the fluoride as prescribed. It might have limited functional improvement because, as we said, it helps with the bone resorption, but it does not provide additional retention unless you add the retentive elements. The teeth are still susceptible to periodontal disease. If you have bony undercuts, especially in the canine areas with the canine eminences, it might not be possible to maintain those canines. because of path of insertion of the prosthesis. And then other less frequent complication, denture fracture, teeth fracture, denture teeth fracture, which is common for a removable prosthesis. So it is a valid option. You can use it once you have a patient that's partially edentulous and your plan is to extract most of the teeth because they're not restorable, but you can consider save a couple of them. Usually you want to maintain strategic teeth, which is the canines, mandibular canines or maxillary canines. And you need to take into consideration all of the disadvantages in order to manage them. Even if you can gain 5 years, 10 years, for some patients, that's enough. So long-term maintenance, you can see that a large percentage, 90%, will require some denture adjustment. 77% will require a reline, and that is over a time of almost 10 years. 60% may require a refabrication of the denture, 33% clinical remounts, occlusal adjustments. So you can see by this long-term evidence that we have what kind of adjustments an overdenture would require. But considering the low initial cost and the easy maintenance that the patient have for such a prosthesis, those adjustments may be justifiable for a percentage of your patient population. And that is why it's important to know what advantages, disadvantages, and long-term maintenance is, so you can communicate it to the patient, and the patient then can make the right decision. Okay, and now that we know everything about tooth retained overdentures, let's move on to implant retained overdentures. Obviously, once implant dentistry came into our lives, it modified every single treatment modality that we know to the better. So when we're looking at implant retained overdentures, what are the indications? Again, preservation of the alveolar ridge. You can use them when you already have bone resorption, and as we said, we don't have a good foundation for a good denture support. And of course, we need patients that can have a small surgical procedure done. So medically cleared patients for surgical procedures. Advantages would be that it will again reduce the bone resorption, since if the implants are healthy, the bone should not resorb over time as much as if we had no implants or no teeth. It will significantly increase stability and retention. Very, very different than the tooth retained overdenture that I told you. There, it's somewhat improvement only from a support standpoint. Here, stability and retention is completely changed because the implants will actually have retentive features that will keep the denture in place very safely. It will significantly improve patient satisfaction and function, completely much more than what the tooth retained overdenture would. There is no caries risk, obviously, and it's a very easy surgical procedure, especially when we're talking about the mandible. Disadvantages for implant retained overdentures would be medically compromised patients that could not get clearance from their physicians for other systemic diseases to have surgery. And that's true for any implant dentistry procedure. Severe bone resorption, where the available bone volume is inadequate for implant placement. And there we have the discussion where extensive graft needs to be done, or implant dentistry is not possible for that particular patient. It does require surgery, so except from the medical clearance, it's also patient preference. Many of them don't want to put themselves into additional surgery. Pre-operative evaluation of intraocclusal space, very important. And this is something that I am very passionate about because I see it every day, especially with my residents' cases where the implants have already been placed without the surgeon having calculated the restorative space, and we don't have any space for our dentures. Peri-implantitis, definitely any implant patient, we have to assess the risk for future peri-implantitis. Maintenance is equally important as if you have your own teeth. When we do implants, it's not something that the patients should just say, okay, I'm done, I have my implants now, I don't need to take care of them. They need care, maybe a little bit less than teeth because you don't have the risk of caries, but they need to know how to take care of them. And then you do have some denture loosening because of wear of the attachments, which is the most common complication of overdenture and also extremely easily fixable. So now that we covered the implant overdentures in general, I have divided them in maxillary and mandible because they're actually very different. I'll start with the mandible. Why? Because this is where implant overdenture started, mandible. Why? I think the reasons why we started from the mandible as a profession to focus on implant overdenture is, first of all, because the denture surface, the denture covering area, is much smaller than the maxilla. In the maxilla, we have the palate, the roof of the mouth. So it makes it it gives a much broader and much bigger denture surface area to support your prosthesis. On the mandible, on the other hand, it's such a smaller denture base area with the tongue and all the muscles moving around that makes the lower denture so much more unstable. In addition to the small area, also, as we said, we have all the muscles and the attachments. Every time we move the tongue, the cheeks, everything, it makes it even less stable. And then we know from literature that the mandible will resorb 4 times faster than the maxilla when the teeth are extracted. So it sounds like the mandible is not a good location to support a denture because of all of those limitations that it has. And that is why, as soon as we came up with implants, mandibular 2-implant retained overdenture became the standard of care. In 2002, there was a consensus where they decided that this treatment modality should be the standard treatment that we provide to all of our patients that have completely edentulous mandibles. And ethically, nowadays, we have to provide that as a treatment option. Even if the patient does not want surgery, cannot afford surgery, whatever the reasons are, when we are describing the treatment options, it is our ethical responsibility to inform the patient that for your mandible, I can do a denture, but I can also do an implant retained denture that will improve your quality of life significantly more than just a denture because of all of those reasons. So the patient is informed. So the design for the mandible is very reliable. We have a lot of literature to support it and very predictable. We know that we need 2 implants. Location should be between the 2 mental foramen. And it can be either on the canines area, it can be either on the laterals, mandibular lateral incisors, and there has been research on the exact location, and the answer is it depends on the arch shape of the mandible to decide where is the best location, whether it's canines or laterals, for the implants to be placed. And as far as attachment type, unsplinted. Unsplinted attachments, prefabricated at a fraction of cost of bars, very easily inserted, very easily maintained from patient standpoint and from doctor standpoint. When it comes to the maxilla now, things are not as clear. We do not have the same level of literature evidence of the maxillary overdenture as a treatment option. And there is a lot of discussion. What is the ideal number of implants that we should have for the maxilla? There are studies that say less than 4 implants or more than 4 implants. But 4 seems to be this magic number that most of the studies talk around. Location, should they be placed anterior, posteriorly? Anteriorly is anterior to the sinuses, include the sinuses, better AP spread, the anterior and posterior implants, not very clear at all on the literature. Attachment type, should they be splinted or unsplinted? Splinted was what was traditionally used, unsplinted now. We have much better attachments, but is it wise for the maxilla to use them or not? Prosthesis design, should we cover the palate or not cover the palate? The reason why we use to cover the palate is because we need the area for support for our prosthesis. Now that the implants are doing most of the work, is it necessary? And if we don't cover it, is the prosthesis strong enough for it not to fracture? So you can see that we basically have only questions about the maxilla at this point. And I think the reason is because traditionally, the maxillary overdentures was not such a big need as the mandible. because we have the palate for additional retention support, and because patients seem to tolerate maxillary overdentures much better than the mandibular ones. So we did not need to look into finding alternative treatment solutions for the maxilla as we needed to do that for the mandible. So for the maxilla, once they start considering maxillary overdentures, at the beginning they were splinting the implants together with casts, at that time, bars. Later could be milled bars. And the reason was because the implants, when we started using them, they were not as surface treatment was not as evolved as now. So they were trying to splint them together, distribute the forces so that they have better long-term success. However, doing a bar, except from the fact that it's significantly more expensive, it also creates prosthetic problems because we struggle to find space for our prosthesis. Biologic problems, we have seen a lot of complications with tissue overgrowth and patients' inability to clean underneath the bars, hygiene, maintenance, and even phonetic problems, aesthetic problems, and all of that because of restorative space limitations. So we know that it has many limitations as a treatment option. And on the other hand, we know that we may not need maxillary overdenture as much. So where do we go from there? Why don't we start exploring unsplinted? Now implants have changed completely. The surface treatment almost guarantees osseointegration. Why don't we start looking at unsplinted that are so easy to install, so easy to maintain, require so much less restorative space? So this is what an unsplinted would look like as compared to a splinted overdenture from the other photo. You can see here the health of the tissue, how simplified the design is, how easier for a patient to maintain and for us to install. When we're looking at evidence, as I told you, for the maxillary overdenture, let's look at this systematic review from 2016. They evaluated 20 publications, and they found that that included maxillary implant retained overdentures, and they found that prosthesis retention was mainly designed with bars for the maxilla, either milled or prefabricated. There was a very limited number of unsplinted designs, studies, and they actually found no difference in the outcomes between splinted and unsplinted design. But for all of the studies, the sample size was very low. And there were so many other variables that make statistical analysis very difficult for something like that. So it's clear that we didn't have much evidence or good, strong evidence as far as maxillary overdenture. And that is why this is a topic that I decided to actually conduct a study when I was at the University of North Carolina as an implant fellow. And the study that we designed was a retrospective cohort on maxillary overdentures using unsplinted implants. So the goal of our study was to retrospectively assess the unsplinted implant retained maxillary overdentures by evaluating the implants and their related complications, their maxilla, the prosthesis, the overdenture, and their related complications, and then the patient satisfaction and quality of life. So the way that we did that is that we recalled patients that have already been treated with maxillary implant retained overdentures. And when we were looking at the implants, we were looking at the system that was used, the exact location that was used, the probing depths, the radiograph if we could, if there was plaque, bleeding, any variable that we could evaluate from the implants. And when we were looking at the prosthesis, we were looking at the design of the prosthesis. Did it have a palate? Did it not? Did it have a metal framework? No. What was the occlusal scheme? What was opposing? What was the occlusion with the opposing? Every single factor as prosthodontist that we can evaluate, I was evaluating it for all of those patients that had already been treated by this treatment modality, but we have so little evidence on our literature. At the end of the treatment, in addition to simply only doing a clinical evaluation, I gave the patients 2 questionnaires. One was the patient satisfaction questionnaire. Questions were how do you find your prosthesis in general? How did your expectation become real with this? It's 20 questions, scale from 0 to 10, from totally dissatisfied to completely satisfied. And at the same time, we also gave them the oral health related quality of life questionnaire that has 49 statements that are formed into questions. And it's a 5 Likert scale from never experienced to all the time, to very often. And this is actually a tool that is used and it's published in many studies. So we use this in order to be able to compare our results with other studies that study quality of life. So what we found from recalling those patients, we were able to recall 44 participants, which even today makes our study the largest sample size of patients with maxillary implant retained overdentures. The mean observation or time service time of the prosthesis was almost 5 years, 4.7 years. So it's a good short-term study to show us how the denture has been performed in the first 5 years. So from the overdentures that we assessed, we had 100% prosthesis survival, meaning that none of the prosthesis needed to be remade, repaired, or anything like that. From the 171 implants that we assessed, we found 98% implant survival. Only one patient had 2 implants that had failed out of all of the ones that we saw. If we look a little bit closer at the demographics, those were some of the demographics that I was evaluating when I was looking at the patient, and I will just bring your attention to a couple of them. And you will see that as we go into more details, gender, opposing dentition, and mucosa health were the 3 factors that mostly affected the patient satisfaction or quality of life when they were answering those questions. So we had close to even number, 57 male, 43 female. You see that opposing dentition, it had different options. It could be a mandibular overdenture, you could have mandibular natural dentition, or a mandibular hybrid, or a mandibular partial denture. And as far as the mucosa, most of the patients, about 60%, they had healthy, but 40%, they had some sort of stomatitis, and I'll show you what that was. The rest of the factors, age, time of service, smoking, did not really have an effect on their satisfaction and quality of life answers. So here, if we look at the satisfaction, the higher the numbers here, the greater the satisfaction with the treatment that we provided. And you can see here that the vast majority of the patients, their satisfaction was pretty high. There were a few that we call them outliers, and those were the ones that we investigated a little bit closer to see why. Similarly, when you look at the oral health related quality of life results, here the lower numbers indicate better oral health related quality of life. And you can see that most of the numbers are pretty low, and again, very few, just moderate, not very high. To put into perspective the quality of health related quality of life, I have this graph here so that you can understand how it relates to other treatment modalities or natural dentition. As I said, the OHIP questionnaire 49 is a tool that has been used extensively in the literature, and it's important when you design a study to try to use tools that have already been used so that your study results are comparable to other studies. So you can see here that for a dentate patient, meaning patients that are having all of their natural teeth, the OHIP score is very low, 5 to 10, depending on what study we study. If the patient becomes partially edentulous and we provide a partial denture, then you see the OHIP score increases. Once we use an implant to retain that partial denture, the OHIP score drops again down to about 20. When we're having completely dentulous patients and we're giving them dentures, their OHIP score, their quality of life, increases up to 80 or 90, depending again which study you study. Once we do a mandibular implant retain overdenture, their scores drop again very low to about 20 to 30, again, depending on the study, which is the reason why mandibular implant retain overdentures are considered the standard of care nowadays. And our study shows with our results that if we do maxillary implant retain overdenture, then the patient OHIP score drops again significantly, and the patients almost perceive themselves as completely rehabilitated. So that's, I think, the main point from our study, to see how our results and the oral quality of life is related to dentate patients' dentures, and how you can present it to your patient. For some of them, that they do want to change their lifestyle, their needs have changed, and they want to improve their mastication, their aesthetics, their function, their phonetics, and all of those things. So the conclusions of our study was that unsplinted implant retained maxillary overdentures are related with high implant survival rate, high prosthetic survival rate, and high patient satisfaction and quality of life. So now we're going to move on to clinical case to put everything into perspective. This is the Parthenon from Athens, Greece. This is where I come from, and this is actually a hotel right across from the Acropolis and those ancient monuments that are there, obviously over 3,000 years now. And I hope that we can travel again so I can go back to my country eventually. So now let me introduce to another patient. This is an actual real patient that comes to our practice. You can see this patient, she was mid-50s or mid to late 50s. Her main concern was aesthetics. She was not able to smile. Clinical evaluation, you see that she suffers from partial edentulosum, several teeth are missing, caries, recurrent caries, recession, which means periodontal disease, malocclusion due to lack of posterior contacts for posterior support, several problems. And in order to treat her, we had to remove most of the teeth because of financial reasons. Obviously, we presented the patient with the option of doing a full mouth rehab, but for financial reasons, the patient could not agree with that. So this was a case where we decided to go with maxillary tooth retained overdenture and mandibular implant retained overdenture. It is very important to listen to the patient and their needs. When we're presenting treatment options, we go from ideal to more compromised. An ideal for her would be to extract the non-restorable teeth, caries control, implant fixed prosthesis for the posterior partially edentulous areas, and then full coverage crowns for the anteriors. The patient was not compliant, could not afford the treatment, and was not even interested in extensive surgery. So we went down to our third and fourth option, which meant that now we have to edentulate most of the teeth, remove the teeth. And then because, as I said, the patient was around her 50s, and she would still have several years to live, I proposed to just leave a couple of teeth on the maxilla so that the maxilla does not resorb as much. And then on the mandible, we would do the standard of care with the two implants. So the first phase of treatment was to extract the non-restorable teeth, was to do endodontic treatment on 6 and 11, and decoronate those teeth and give the patient an immediate interim dentures, maxilla and mandible. So this is only a few days after the extractions. Patient came for an adjustment of the overdentures. Basically, we did disease control. We eliminated periodontal and caries. Patient disappeared for a year. It's not how we want it to be. We had a plan on about 6 months to reevaluate the patient, but that speaks to the compliance and how important it was that we listened to the patient and we didn't move on to an extensive, expensive full mouth rehab. So patient comes back after a year. We see very good healing of the ridges. We see some redness, and that's so normal because it was immediate dentures. They were relined with soft reline. She never came back to change it, but nothing too bad, nothing that would worry us, and nothing that wouldn't be fixed with a new, clean, fresh reline of the immediate dentures. So At this point, our plan was to proceed with the mandibular implants. So in order to do that, we had to create a radiographic guide in order to take a CBCT or a panoramic radiograph. And it was very obvious here that we don't have restorative room. You see how limited the restorative space is. I used a wire on the occlusal surface of the mandibular teeth because I wanted to see what the height would be from implant platform to the incisal edge. This is how we determine restorative space. And we saw that we needed to do some alveolasty. We used this guide to communicate with the surgeon and see here the implants were placed with some alveoloplasty that was done. For the maxilla, you notice that I had used amalgam. And based on what I said a little bit ago, I shouldn't have used amalgam. I should have used something that releases fluoride to prevent caries from forming. Well, I used amalgam because we had to decoronate those teeth the same day as the teeth extraction. So there was a lot of blood, very difficult to control moisture. So we used amalgam that it's a little bit more forgiving in those kinds of situations where moisture control is not possible. And now, when we were ready to proceed to final restoration, I removed the amalgam about 2 millimeters from the gutta percha and then covered the area with resin-modified glass ionomer, which gives us the fluoride releasing effect, and also with the resin that it includes helps with the bonding the tissue, the teeth, so it will have better long-term success as a material. So we started a patient that came to our office like this to this. And just looking at that, many people might perceive it that we didn't go the right direction. We did not improve the patient's situation because obviously as doctors and as dentists, we want to maintain as many teeth as possible. But that's not true because we need to listen to our patient. And this patient was not going to be compliant, was not interested in trying to maintain her teeth. So we removed the disease. The patient on the right photo has no disease, is completely healthy. And because of that, we're able to prosthetically rehabilitate the patient to improve function and aesthetics on a disease-free environment, intraoral environment. So we took a patient actually that did not allow me to take a smile photo on the first appointment, which is something standard that we do for all of our patients, to a patient that dressed up and did her hair and, you know, necklace and jewelry and everything on the last appointment to take a smile photo. So although we don't want to take our patients from teeth to no teeth and dentures, knowing how to fabricate overdentures correctly, knowing how to give a healthy environment to the patient and educate them, you can take a patient from a very sad and dissatisfied situation to a very satisfied situation with overdentures that is more affordable and easier to maintain. As far as design, really quickly, if you want to implement this treatment option in your practice, remember for maxilla, we know that we need 4 implants and they don't need to be splinted now, depending on path of insertion. But what's important when you're fabricating your prosthesis is to always incorporate metal. We can do them without covering the palate, which improves patients' taste, speaking, everything. But we need to add metal, and it can either be exposed or embedded inside the acrylic, but it will really add to the strength. It's not something that we can compromise. It will reduce the fracture of the prosthesis, and it's almost necessary to do it. For the mandible, it's not as crucial. Mandible, we don't have to always put a metal meshwork. We can, and it depends on the restorative space that we have. If you feel like restorative space is inadequate and you do feel like you run the risk of fracture, then definitely incorporate it. But usually if we've done enough alveoloplasty or the bone has already resorbed, because we said it resorbs 4 times faster than the maxilla, then you usually have enough thickness of the acrylic that will not fracture. As far as attachments, the most commonly used and the most commonly studied in our literature is the locator attachment from Zest company. You can use it for teeth retain overdentures. This is what I have on the blue side of the sheet, or for implants. This is on the right side of your screen. It has exactly the same retentive element on top of it. It can be gone inside a root canal tooth or inside your implant. Then the denture will have the male portion in it, and it's plastic analogs that are very easily replaceable, and they have different retentive strengths depending on the patient's needs. Then we have the extended range, which are having only one retentive element instead of two, but it allows for misplaced implants that are not parallel to each other, which is it shouldn't be a problem on the mandible because it's an easier surgery and the implants should be parallel to each other. But the maxilla, depending on the resorption pattern of the maxilla, it might be challenging sometimes for all four of them to be parallel. So having the extended range in your pocket is very useful. And now the same company came out with even more extended range, the RTX attachment. This allows for 60%, for 60 degrees divergence. Again, on the mandible, it shouldn't be a problem if you have planned the implants correctly. Of course, if the implants have already been placed and you had no control over it, then you need to be able to adjust them. But for the maxilla, that's when you may run into problems of the implants not being parallel to each other. Those are prefabricated. Those are not the only ones. Those are just the most commonly used ones. You have ball attachments, you have other companies. And now, as dentistry is moving into digital significantly more, we can have custom abutments. One of the first companies was Atlantis from Dentsply and Conus abutments, where you actually make a conventional impression of your implants, and then the company will mill custom abutments for those 4 overdenture implants, and then you just pick them up intraorally like you would do with the prefabricated ones. And this, because they're so parallel to each other, it can correct angulation issues from already placed implants misplaced, and it can improve the retention very much. It can actually improve the retention so much that in some cases it's very difficult for the patients to remove them. So very careful when you prescribe that. Maybe very elderly patients with dexterity issues might not be a good indication for that. But for younger patients, maybe 40s to 50s, definitely consider something like that. And again, remember, we always advocate maxillary overdenture to have a framework, metal framework, not like this photo. This is actually a trick photo. It should have a framework in it. And just as we close and we're moving into digital dentistry, we're going into digital dentures more and more. We have monolithic dentures where the teeth and the acrylic are milled together nowadays. It gives for a much stronger prosthesis. That will be combined with overdentures in the future. For now, we still make our conventional impression that we send into the lab for them to digitize it. And then they have digital MMR, maxillomandibular records, where they will set up the teeth, and then they can either give us the final prosthesis or some sort of try-in if we want to do try-in and then go to final. As we're moving into the future, we're going to look at intraoral scanning of soft tissues more and more. It has already started, but definitely not where it should be. It's just the beginning. Everything starts from somewhere, but I think it's only a matter of time until they figure out how to accurately scan soft tissues. And this is the result from soft tissue. So I put everything together just in a nutshell, the overdentures, so that you have them in your mind and you can use it when the right indication is there. We have tooth retained overdentures and implant retained overdentures. Both teeth or implants, you can have splinted or unsplinted, the remaining abutments. For teeth, when you do unsplinted, you don't have to use a coping. Just cover the access hole of the endodontic treatment with a fluoride releasing material, or you can use a coping with or without an attachment. And then for the splinted, you can use a bar. When it comes to implant retained overdenture, for the unsplinted, you can use prefabricated attachments on your implants, locator or ball attachment, or many others from other companies. or you can have custom abutments that can either be cast or CAD-CAM. And for splinted, a bar, again, milled or cast bar. And with that, I would like to thank you all for your attention, the kind invitation. It's been an honor, and I'm happy to answer any questions.
Thank you so much, Dr. Anadioti. This has been very, very good. For me, I'm still going to go back and listen to the videos and just pay very close attention. A very good summary here. I'm going to go ahead and run a poll. We have 6 questions, and I need us to, your participant is going to go through the answers at the end of 4 minutes. So as before, just go ahead.
Healing Hands Health Society presents Dental Webinar Series. We have planned a series dental webinars to keep you abreast of current practice. This series on prosthodontics will be via Zoom, Facebook Live. Presenters are drawn from dental schools in the USA, private practitioners from around the world. To register for future webinars, visit www.hhands.org/dental-training. For future inquiries, contact Facilitator